Hello and welcome to the Research Sofa from the Closing the Gap Network. I am Simon Gilbody from the University of York, and today it is my absolute pleasure to speak with my colleague, Professor David Osborn from University College London. And David's going to tell us a bit about his work and about how he thinks we might begin to close the gap in terms of physical health for people who use mental health services. So hello, David. I wondered if you could begin by telling us a little bit about yourself and why you became interested in the health gap for people with the most severe forms of mental ill health.
Sure, yeah, thanks. So, yeah, it goes back a long way, in fact, now for me. So I'm a psychiatrist, for people who don't know me. So I trained as a medic and then in psychiatry. And it's interesting thinking about when I was a young lad going first onto the psychiatric wards and, having done all my medicine, I was just a bit horrified to see that people were inpatients, but just weren't having their physical health looked after. So it just got me interested straight away, thinking about this terrible way that people either think about physical health or mental health and never think in a holistic way. So that drove everything forward, really. And I went off and did my academic training, really, to be a researcher. So I was very lucky. I got some funding from the Medical Research Council, and I did a PhD here in Camden, really looking at people's cardiovascular risk factors when they had either schizophrenia or bipolar disorder. And that was it, and really found from there that people had, often had high levels of smoking that we know about, but also high levels of diabetes and also problems with lipids. It was the first piece of research that I really published around this. And it went from there, really. And I think you're going to ask me questions about that going forward. But it still worries me that we have this, people call it dualism sometimes, that once people think about mental health, they forget all about physical health. But we're all here as whole human beings with our mental well-being and our physical well-being totally intertwined.
I mean, that's so interesting. You talk about this mind-body split and dualism. And I think one of the things that shines right through your work is ensuring that physical health and mental health are on the same page. And most of your research that I know about has been in the area of heart disease and how that might be prevented or treated amongst people with severe mental ill health. Could you tell us a little bit about why heart disease is so important in this population?
Yeah, for sure. We know that for the general population, heart disease and strokes as well are some of the biggest problems that cause early deaths for people in the general population. Sadly, the problem is just far more prominent for people with severe mental illness. So we've done some of our kind of big data studies where we've looked at large populations across the UK, really following people up for many years. And sadly, what we found is that if you're under 50 and you're somebody with severe mental illness, you're 3 times more likely to die from a heart attack or stroke than somebody in the general population. And even up to 70 years old, you're twice as likely to die from heart disease and stroke. So, the thing is, this is something we can do something about. We can support people with this if we address things like smoking, address things like diabetes, blood pressure and cholesterol. Then there are effective treatments here that we can offer to people to try and prevent these early deaths from heart disease. So it just has to be key to what we're offering to people as part of their overall care package.
I mean, those statistics are really arresting, David, and it's interesting to hear that you've made some of your greatest contributions in managing cardiovascular risk. And one of the studies that I've been particularly interested in over the years is the Primrose Study. And I wondered if you could tell us a little bit more about the Primrose Study, about that study and what it was that you found.
Of course, yeah. So, Primrose was a study in general practice across the UK that we're doing for almost 10 years, would you believe? So we started it back in 2010. And we wanted to put together kind of the best care package that we could think of for people with severe mental illness to try and improve their cardiovascular health. So we did lots of work bringing together all the evidence at the time, had lots of really important discussions and qualitative work with service users, but also with GPs, with psychiatrists, with nurses, saying, what could this look like to try and get a really good care package together for people? And we came up with our Primrose care package. So I almost forget what Primrose stands for now, it's so long ago, but we had a catchy logo with primrose petals on it. But the key important thing was what was in this intervention. So it turned out we did a big trial here in 76 general practices across England. So we're up in the northeast, over in the northwest, down on the south coast. So it was pretty good coverage. And over 300 people took part in this study. And what we offered to people, I'll quickly tell you what was in the package. We really wanted people work in their practice with a healthcare assistant or with their nurse, and they came up with their own care plan over a year, where they tried to improve whichever risk factors they felt were a problem for them and needed to be addressed. So it could have been smoking, it could have been weight gain, it could have been blood pressure, it could have been diabetes. But they came up with this care plan, which was collaborative, and then they met with their nurse over a period of a year. And of course, in the study, what we wanted to see was whether it had an impact on their physical health down the line at a year. So it's quite an interesting study, Primrose, the findings. I mean, the headline is it went down really well. So we had really good attendance. People came along to the appointments. They set goals with their healthcare professional. But interestingly, because half of the practices had the Primrose intervention and half had normal treatment. And in fact, what happened over the year of the study was people got better in both sides of the trial. So although we were looking in our kind of researcher way to see whether it had an impact on cholesterol, actually cholesterol went down a bit in both arms of the trial, but there wasn't a difference. So, statistically, you might say, oh, well, what's the point? I think the beautiful thing about this was a program grant funded by the NIHR, and we were able to do lots of more in-depth work looking at what happened in Primrose. And as I said, it was delivered really well. We know that people's cholesterol did get better in both arms of the trial, but there was a really interesting other finding, which was that people who received this additional care in the general practice were actually less likely to be admitted to psychiatric hospital a year down the line, which is fascinating, really, because we were working mostly around physical health, but there was obviously lots of support there in primary care. And in fact, because people had fewer relapses and admissions to hospital, actually also the costs were lower in the Primrose study. So, there was so much there to learn, really, about how people really value this work, people engage in this work. But I think you've also got to remember that it does show that you need a really properly sustained effort to make a difference here. So I guess we learned lots of things from Primrose. I hope I've summarised some of the headlines there.
I mean, it was such an impressive piece of work, and it was done at scale, and you've given some hints as to the magnitude and the scale of that programme of research. And I was really taken by some of the compelling stories that came out of how excited people were to have someone take notice of their care and help them coordinate that. So, I mean, having thought about the results you found from Primrose and taking a step back, what do you now see is the most important thing that should happen to try and help close the gap for people with severe mental ill health?
So I think what we've shown is we know what the problems are, and we know that we can do something about them. I think we've learned from Primrose, but also from your work, Simon, kind of fantastic work in smoking cessation, that we can do something about these different risk factors, but actually it needs a sustained effort. So we can't just think, oh, well, we'll just go and give somebody a booklet that will work. Primrose worked over a year period, and so with your work in Scimitar, that worked over a year. And we really need to be investing in really robust pathways for people with severe mental illness, for things like weight reduction, for exercise, for smoking, and then for lipids and diabetes. So that's what we need, and we need it to be consistently there, really, and offered to people. The big thing that I also talk about a little bit with Primrose is one of the things that didn't happen in Primrose, although it was well received and well taken up. One of the things that didn't happen was people weren't talking about statins for people. And I'm not some big, pusher of medication for medication's sake, but we know statins are a big lifesaver when people need them. And unfortunately, I think we found that people tended to have conversations about things other than medication in Primrose. So perhaps one of the reasons we didn't see an impact on cholesterol was that conversation about statins didn't happen. So we know from some of our other big data studies that statins do work for people with severe mental illness in bringing down cholesterol. So I think that's the other key here, that again, not for everybody, but when they are indicated for people, then that really needs to be one of the priorities, that people at least have equal offering of those life-saving medications. So.
David, that's so interesting, and finally, congratulations on delivering such an interesting and important program of research. And I could speak to you for hours about it. So I'm just going to finish by thanking you for speaking to us on the research sofa today. And I hope this isn't the last conversation, because I know you've done so much work in this area. So I'm hoping we can speak to you again in the future. So thanks again, David.
It's an absolute pleasure. Thank you. And thanks, of course, to all the people who worked on Primrose, because it certainly wasn't just me. It was a big, big team, and all the parties.
Amen to that.
Cheers.